good evening. I think we have to start the next session. It will be about two important interventional procedures, which is getting now a wide area in the application in interventional cardiology, and it's taking place from surgery. The first presentation will be about post-CABG intervention. I heard from my dear colleague, Dr. Magdy, that it will be in form of case presentations, not a live in a box. I think we will see many interesting cases about this very important procedures and see how can we promote and avoid the complications that usually happen in this state. Dr. Magdy.
Good afternoon, everyone. Thank you very much, Professor Omar Awad, Professor Sharif Al-Tughi, dear friends and colleagues. This is a very important topic, which is post-CABG PCI, very commonly seen in the daily clinical practice. We know that vein graft occlusion and vein graft stenosis represent around up to 25% within 12 months, and degenerative vein grafts and new intimal hyperplasia and accelerated atherosclerosis are responsible for vein graft occlusion. So we have to know tips and tricks how to tackle these lesions. A lot of questions should be answered regarding the use of guiding catheter, type of wires, to predilate or not, the risk of PTCE, the risk of distal embolization, vein graft occlusion, the need for use 2B3 receptor antagonists or not, the value for using embolic protection devices, is it indicated or not? So a lot of questions should be covered in this session. We have three interesting cases, native vessels, vein graft, post-anastomosis, very interesting and challenging cases. And I had the pleasure to introduce one of the rising stars in our department in intervention cardiology. Dr. Karim Mahmoud is a lecturer of cardiology at the cardiology department Cairo University. كريم أكتر واحد بشتغل معاه، وهو يعني الحقيقة رتب الحاجات وأنا حبيت إن هو يقدم الحاجات، وأنا هشترك في الدسكشن مع حضراتكم وهنضم لل distinguished panelists بروفيسور حسام أنديل، بروفيسور حمزة قبيل، بروفيسور محمد غريب، بروفيسور باسم ظريف. Again, I'd like to thank the organizing committee and the chairman of this meeting. Thank you.
Thank you, Dr. Magdy, my dear professors and dear colleagues. Good afternoon. We will demonstrate different cases of post-CABG intervention. At first, we have some issues regarding the vein graft angiography. It is associated with increased contrast used, so it might lead to contrast-induced nephropathy. It is associated with increased radiation, long procedural time, and due to the manipulation, we might have a higher risk of thromboembolism and aortic injury, and we might have a risk of injury to the subclavian artery and the lima during the lima intervention or lima angiography, and the difficulty in engaging the vein graft that might be angulated and the subclavian artery in some patients. So this is a special issues related to the vein graft angiography, and we'll move to the first case, which is a 50-year-old male. He is a diabetic. He had CABG at 2007, and he presented with chest pain, Canadian class 3, at May 2017. His echo showed an ejection fraction of 50%. He has a normal GFR. His multi-slice CT showed a patent lima to the LED, patent saphenous vein graft to the second diagonal, the chronic total occlusion of the proximal part of the right coronary artery, and significant left circumflex OM bifurcation lesion. He was on this treatment: aspirin, metoprolol, valsartan, rosuvastatin nitrates, and clopidogrel was added to his treatment, and this is his coronary angiography. As we can see, in the left coronary angiography, we had after the diseased left main with a total occlusion of the left anterior descending at its ostium, and the long lesion in the circumflex and the obtuse marginal branch with a bifurcation lesion 011. The right coronary artery is totally occluded from its proximal segment, and the lima to the LED was patent with occluded saphenous vein graft to the right coronary artery. So what would be your, our management? Let me remind you with the first this is the left coronary angiography. And Dr. Sharif, Dr. Omar, what do you think about the best management for these patients?
It depends on the viability of the myocardium in the region supplied by the circumflex and the right coronary artery. في الcircumflex هتعمل bifurcation management, probably need two-stent technique. Right coronary artery depends on the viability of the inferior wall.
Okay, so the viability might add information to this this clinical data of these patients. However, the patient is presented with a recurrent attack of chest pain, Canadian class 3. As we know that for the patient was post-CABG, the BCI is the preferred revascularization method. And the BCI of the native vessels, if feasible, will be preferred than the BCI to the graft vessels. So, as Dr. Sharif said, it's a complex bifurcation for this left circumflex obtuse marginal branch. Dr. Bassem.
Can I have a question, please? Regarding the coronary angiography, do you have any evidence that the distal part of the
مايك يا باسم.
في ميكروفون يا باسم، في ميكروفون عندك.
مفتوح.
Do you have an evidence that the RCA distal part is filling from anywhere? And second important thing regarding the circumflex. The circumflex, I think it's a co-dominant, or what do you think? So if the RCA is totally occluded and there is no distal bed that's filled from anywhere, so it's not worth trying, and the culprit will be the circumflex.
Thank you for comment, Dr. Bassem. Dr. Bassem, comment about the distal filling of the right coronary artery, which was not apparent in any view. I can see the right coronary angiography, the right coronary artery distal filling of the right coronary artery. And as you mentioned, Dr. Bassem, the circumflex is large and might be a co-dominant branch, so and supplying a large territory of myocardium. So the revascularization of the LCX and obtuse marginal branch might add a benefit for this patient and might eliminate the ischemia that the patient presented with.
But Karim, most probably he is co-dominant because he is already having a graft to the right coronary, which means that the right coronary is a big artery. And another point for discussion is the point of viability. Now there is some debate about the importance of doing viability study after the stitch trial, and they are telling that there is no great difference whether you make it a viability or not if you have an evidence clinically and by echocardiography that the myocardium is viable.
Okay, thanks. So continuing our case, we have a guiding catheter. It was an XB6 3.5 with passage of a 2-horse wire into the LCX and the obtuse marginal branch. Here is a first pre-dilatation of the LCX with a 2.020 balloon, pre-dilating the whole length of the LCX. This is the control angiography after the pre-dilatation. Then passing a stent into the distal LCX, it was a 2.25, 33 zetrolimus eluting stent, followed by another stent which are 3.5, 30 millimeter zetrolimus eluting stent into left main LCX. There is some indentation in the stent at the origin of the obtuse marginal branch, and this is a control angiography with some pinching of the ostium of the obtuse marginal branch. So a pre-dilatation was done with a 3.75 millimeter 12 balloon. This followed by the recrossing into the obtuse marginal branch and doing a pre-dilatation with a smaller balloon, 1.25 millimeter, then a 2.0 balloon. And the 2.0 balloon was used to dilate the whole length of the diseased segment in the obtuse marginal branch. The control angiography after the pre-dilatation showed the presence of a long dissection in the obtuse marginal branch. So the two-stent strategy was intended from the start, and the TAP technique was the technique of choice here. And a 2.75 millimeter 38 zetrolimus eluting stent was passed into the obtuse marginal branch with a 3.75 non-compliant balloon in the LCX. And this is the result after the deployment of the OM stent with doing a kissing balloon using the stent balloon and the non-compliant balloon in the LCX. Here we can appreciate that the result is still suboptimal regarding the bifurcation. So kissing, a second kissing was done with a larger balloon, followed by a pot with a 3.75 12 balloon in the LCX. And this was the final result in the spider view and the areocaudal view. So I appreciate comments from the panel.
Panel, any comments? The panel.
I think this is the final view.
Yes.
This final view. There is some possibility of thrombus in the obtuse margin.
Don't think so.
There is haziness in the proximal parts of the obtuse margin. Can you make it again? In the same view we are seeing before.
This is a spider view, and might be.
Yes, there's some haziness. Yes,
might be.
Could be.
Well, initial pictures I think were very suggestive of very difficult patient to treat. Diffuse disease and calcification, the post CABG من 2007. I think إنه the final pictures هنا are very gratifying. يعني approach was very very good. والpictures دي ورت إنه supplying التيريتوريز LED احنا شفنا ليه مع LED was good. التيريتوريز دي الرايت كورونري مقفول ف supplying البيج circumflex ده وهو supplying good part of the left ventricle and the back wall of the heart I think was very good approach. أنا تخيلت إنه maybe it will be difficult to find الريمس ده to deal with it in this very nice way, لكن it was done. قصة إنه ممكن يكون فيها little bit of thrombosis. I think إنه البيكتشرز في different views مورية إنه الفلو is good. والآن كان واخد line full dose of heparin.
Yes, exactly. Yes. Definitely yes.
I think at least at this stage things look reasonable.
في سؤال دكتور
محمد حلمي.
دكتور كريم, a nice case.
الصوت بس.
But after round you have that technique start by and step to the OM. But if the OM is affected, compromised, it is difficult in situation patient with CABG to enter the OM. So many drugs need start by the OM and then
سؤال حضرتك يا دكتور محمد اذا كان الاو ام ده انا شايفه ان هو diseased from the start to start with mini crush, and the mini crush needs that I should start with the side branch, which is obtuse marginal branch, then putting a stent in the main branch, which is LCX, which is it's a good technique, and it might be beneficial here as well. So I believe we should use the technique that we are used to. Okay, if it's stab, if it's a mini crush, despite the dick crush have a lot of data that are favorable, but it also have a lot of criticism regarding its use. So any technique, I think it will be feasible as far we get a good and final angiographic result.
Last question, دكتور غريب عشان الوقت.
دكتور كريم, يعني it's a very nice case, but why you did cover all the length of left main? I can appreciate the left main and the diagnostic case is not so diseased or not diseased. Second thing, because the what is the diameter of the stent deployed in the left main LCX? I think it is 3.5.
3.5, yeah.
And you dilate with non-covalent balloon 3.75. يعني if I were in your place, I could not cover the whole length of left main. Second, the obtuse marginal 2 is totally included now. Obtuse marginal 2, OM2, that is a small branch, but it is totally included after deployment of the distal stent.
Okay.
هو طبعا very good question دكتور محمد, اللي هو why you covered up to the ostium on the left main, because we don't have an IVIS to see the left main if it's significant or not, but it is diseased and there is no risk for you because the LED is totally included and you have a protected lever for the LED. So it should be covered up to the
the final message here in the patient post-CABG, we are expecting to have a complex coronary artery disease. If we have the feasibility to treat the native vessels, it would be preferred than the treating the the diseased graft. So the second case is a 50-year-old male. He is not known to have a diabetes mellitus or hypertension. He had a CABG at 2009 with a Lima to LAD, saphenous vein graft to first diagonal branch and saphenous vein graft to the posterior descending artery. And he presented with a crescendo angina since December 2017. His echo showed an ejection fraction of 45%. He was normal GFR. His multi-slice CT showed a patent Lima to the LAD, a significant stenosis to the saphenous vein graft to the first diagonal branch, and a patent saphenous vein graft to the BDA. He was in the treatment in the form of aspirin, bisoprolol, valsartan, rosuvastatin nitrates, and the dual antiplatelet were started. And this was coronary angiography that showed that after the left main it's okay, and the LCX was atherosclerotic with no significant lesion, and the LAD was totally occluded. The Lima to the LAD was patent, and this was the saphenous vein graft to the second diagonal branch that showed this critical paraosteal lesion that showed some haziness, as we can appreciate here. It might have a thrombus on the top. So the right coronary artery was totally occluded with a patent saphenous vein graft to the right coronary artery. So what would be the best strategy for treating the saphenous vein graft through the PCI?
I think the region here is in the ostia
after the ostium by a few millimeters.
Yes, and as you say, there is some haziness which can suggest the presence of thrombi. Whether we put the patient in glycoprotein and then we do direct stenting to this area, I think this is good. But the question I want to ask about it, that all the literature is speaking about protection against distal embolization. We are, and it is in the literature also that it is under use. Only 20% of the cases with CABG is doing that. What is your opinion about that? Whether you use that in your cath lab or not routinely, and although all the literature is speaking about marked improvement if we use it.
Thank you, Dr. Omar, for both comments. The first comment is in the presence of thrombi, you would use a glycoprotein 2b3 inhibitor and doing a direct stent to minimize the manipulation inside the vein graft and reducing the risk of distal embolization, which is it's a very good opinion. The second comment about the use of distal protection device. It's for years it was a class 1 indication for to use distal protection device for saphenous vein graft PCI, as this was associated with the reduction of distal embolization and reduction of the poor outcome later on. However, in the recent myocardial revascularization guidelines 2010, it was downgraded to class 2A. This might be due to trials that showed a favorable effect with the use of drugs, new drugs, in the treatment of saphenous vein PCI, or might be also due to the underuse, as you said, of the distal protection device in the treatment of saphenous vein graft. Let's vote. How many of us use a distal protection wire for a treatment of a saphenous vein graft?
It is underused definitely, not only here, internationally.
Yes.
In spite that all the studies before are telling that it is very beneficial. And now we are not having only distal protection, we have a proximal protection, and there is some studies comparing the effects of both of them.
The American guidelines recommend to be used if it is feasible. If you have it, you have to be used.
Yes, because, yeah.
I think this is very reasonable because usually it's not feasible. So I think there is a very large difference between what should be done and the practice in this particular. أنا عايز أعلق بس على الليجن اللي في الفين جرافت ده. أما أفتكر كل الفين جرافت ليجنز اللي قبل كده زي 50% كانوا بيبقوا near the ostium كده. I think this is a common location. I don't know why. وال 50% التانيين بيبقوا في وسط الجرافت. قليل اللي بيبقى في الديستال part of the graft. This is just a comment. أما عن حكاية إن إحنا بنشتغل من غير distal protection، فالحقيقة إنه الcomplications, severe complications يعني of distal embolization was not common, at least in my practice. وانا ما بعملش دايركت ستنتنج ابدا، انا دايما بعمل بري دايليشن الاول. I think this is useful عشان at least ابقى عارف الستنت ده راح فين والبوزيشن بتاعه ايه بالظبط.
قبل ما نشوف الدكتور احمد بيه عايز يقول حاجه بالنسبه للنقطه المهمه اللي ذكرها الدكتور شريف بتاعه البري دايلاتيشن. Again, all the guidelines are speaking about direct stenting is better in this condition, and about the undersizing of the stent. Both these remarks are very important together also with the very well known of using a drug-eluting stent. But dilatation, because usually the graft is degenerated and the possibility of no reflow and possibility of destruction of the thrombi, they are not encouraging that. Dr. Ahmad Nassar.
So another important tip, it's undersizing and not inflating the stent on the high pressure inside the vein graft to avoid the risk of rupture of the vein graft.
The point of undersizing, because if we put the proper size protrusion of the thrombi at the site of the stenting is very possible, and this increases the possibility of embolization. But I think most of the literature now is recommending drug-eluting, and pure metal stent is going in the back.
it is better to avoid البريدايليشن لو في big thrombus burden. لان الريسك اوف ديستال امبوليزيشن والنور فلو هيبقى عالي، انما لو ثرومبس بيردن زي الكيس دي مش very big thrombus burden you can predilate.
Okay, this is some issues regarding the BCI in the vein graft and arterial graft. We have a higher risk of distal embolization, as was discussed, with the occurrence of no-reflow during the balloon angioplasty and stenting. We have a higher risk of vein graft rupture. We have a higher risk of restenosis after balloon angioplasty and stenting. As discussed, there is a conflicting data in regard of using the drug-eluting stent in the vein graft, and we might have a difficulty in having a good guide catheter support in a tortuous vein graft or internal mammary artery. And this is a available protection device, as we can appreciate here. So, Amblat's right guiding catheter was used with a passage of regular wire into the saphenous vein graft. This is followed a pre-dilatation. There was a conflict regarding the use of pre-dilatation, but here we use a pre-dilatation with a small balloon. And this was followed by the deployment of a 4O12 everolimus eluting balloon that deployed at a nominal pressure. And this was the final result with a TIMI3 flow in the saphenous vein graft and the distal vascular bed.
One comment, probably this stent should have been a little longer to cross the curve اللي بعد الليجن.
And again, I don't find the great reason for pre-dilatation in this condition. The stenosis is very well evident, and it is localized, and it is very easy to do direct stenting, and we cannot be sure that there is some thrombi which can be distracted by this.
So if we have time, we will shortly discuss this case. Is a 59-year-old male, is hypertensive, he is not diabetic. He had CABG 2007 with a lima to LAD and saphenous vein graft to the diagonal branch. He complained of typical angina and presented at March 2018. His ejection fraction was also 50%, and this was his coronary angiography. There was a total occlusion of the left anterior descending artery with a diseased LCX that showed an occluded first OM branch and diseased small second OM branch, and total occlusion of the right coronary artery that fills with the retrograde collaterals. And this was the saphenous vein graft to the diagonal branch that was fairly patent. And this was the lima to the LAD that showed a significant stenosis after the anastomosis. So in this case, we had to revascularize through the lima because we have a chronic total occlusion at the proximal part of the LAD. So our strategy was passing our devices through the left internal mammary artery. So this was a lima guiding catheter, was using with passage of BT2LS wire into the lima and passing into the distal LAD. Then doing a pre-dilatation to the LAD using a 2O balloon, 220 balloon. And this was the control angiography, followed by the deployment 2.75, 23 stents into the distal LAD, followed by a post dilation with a 3O balloon with acceptable final result. So, I need to have the insight of my professor about the intervention into the native vessels through the vein graft.
I think this is a very reasonable technique, and again, as you mentioned before, that dealing with the native artery is better than dealing with the graft. I think this is a quite reasonable approach.
هو I think انه التشالنجز دايما اكبر في الحالات البوست كابج، وانه يعني كل ما التكنولوجي بيتحسن وكل ما كان يعني احنا كان دايما الليفت مين هو التشالنج، ودايما السي دي او كان تشالنج. الحاجات دي دلوقتي بقت part of our daily practice في الكاس لاب وفي الانترفنشن. فاحنا دلوقتي dealing مع very difficult and challenging cases اللي هي post cabbage، وزي ما احنا عارفين انه الديزيز بيبروجريس very rapidly بعد الكابج، ولانه النيتف سيركيليشن بتبقى باي باس. فالثري اكزامبلز دول وروا قد ايه انه when you have proper equipment و proper، انا لسه كنت بقول للدكتور مجدي والدكتور باسم جنبي quality of images الحقيقه very helping للي بيشتغل في الانترفنشن. والثلاثه على نفس الماشين اللي هي النيو ماشينز دلوقتي بتوري كواليتي اوف بيكتشرز عاليه جدا، وانه ده بيخلي النيد فور اذر يعني ايمجنج اقل. انا شايف الوقت قرب اقول كريم.
No, we have more 5 minutes for discussion.
دكتور أيمن.
دكتور أيمن صالح.
شكرا يا كريم. هو بس ليه كومنت على الجزء اللي هو ندخل عن طريق الانترنال ميموري كورد كوشن لما يبقى فيري تورتيوس ديما فبيبقى لايبل تو سبازم ذات مايت بي لايف ثريتنينج، فنبقى كوشس فيري رابيد. نكون ايضا مستعدين بالبروبر لينك، يعني ساعات بيبقى التورتيوس دي تستهلك البالونه ستاندرد بالون او ستاندرد واير لينك، ففي الاحوال دي نكون بريبير بنطلب من الشركه سبيشال لينك فور بالون. يعني في بعض المقاسات الشاف بيبقى اوف ذا بالون اند ذا بالون كارينج ستنت بيبقى محتاجين نطلب من الشركه سبيشال لينك
or shorting the guiding catheter or shorting the guiding catheter.
ان احنا نقص الجايدنج كاثر، بس طبعا قد يكون افضل نجيب بروبر لينك. الاوبشن الثاني ان احنا ندخل من البريكيال، ندخل البريكيال يبقى المسافه اقصر. هي دي بس حاجه الفيري تورتيوس ليما carries some technical difficulties، بعضها خاص بطول الاكويبمنتس وبعضها خاص بالسبيسز that we should be prepared.
I completely agree. The concertina effect is very common in the cases of tortuous lima, and we might have a pseudostenosis of the left internal memory artery during the lima intervention. The second comment regarding the using of special devices during the lima, the access might be through the arm or through the left radial. We might have a short guiding catheter and or a long balloons or stents to complete our procedure successfully.
Karim, when you decide, still PCI and surgery is both possible in graft disease lesions. When you decide from your point of view that your case should be transferred to surgery, not doing PCI?
This is a good one. So if we have these patients with an indication for revascularization, this patient is indicated revascularization, the PCI is the preferred method for revascularization in this patient. However, if we have this anatomy that is extremely difficult or impossible to revascularize through the PCI, this is the case I would refer my patient to the redo CABG. And you might agree with me, Dr. Omar, these are minority of cases nowadays.
والحقيقة إنه البوست كابج PCI دي is one of the most successful fields of PCI. بالرغم من كل المشاكل والcomplications والحاجات دي، إنما من غير بوست كابج PCI لو تتذكروا البيشنتس دول كانوا they had to either have medical treatment أو and go on with their angina أو إنهم يعملوا redo surgery which has high morbidity and mortality. فالPCI post cabbage PCI دي يعني أنا عايز أزود على التيك هوم مسج دي إن هي دي one of the most successful achievements of PCI. أنا عندي عيان بقاله 12 سنة ولا حاجة، كل سنتين ثلاثة يجي بانستيبل انجينا، كلهم من نفس الفين جرافت للسيركمفلكس، بحيث ان احنا حطينا له في الفين جرافت دي I think 12 ستنت، بس it's still holding.
Any question from the floor? اتفضل.
From your point of view, self-opposing against the balloon expandable saphenous finger الابديت بتاعها.
For me, from my point of view, I have no experience with a self-opposing stents in the vein grafts. All we previously used are balloon expandable stent. There might be one of the attendees that can inform us about his experience in the self-opposing stent in the saphenous vein graft.
Magdy, عندك experience? Okay. I have already used the exposition. خصوصا لما يكون عندك burden, heavy burden, degenerated grafts, has a good outcome.
We will be eager to see the long-term follow-up of these patients.
دكتور أيمن again has a comment, دكتور حسام بيه has a comment, and then we close.
كان في اكسبيرينس طبعا من 15 سنه ما كانش في عندنا كورونري ديديكيتد ستنتس سيركس، وكان عندنا بيشنت عندها اكستنسيف ديزيز في النيتف الفين جرافس بتاعتها اول فين جرافس، فاستعملنا لها بريفرال سمارت ستنتس كانت جرافس كبيره، فاستعملنا بريفرال جراف ستنتس فور سيتنس. طبعا دي اوت اوف ليبل انديكيشن، بس هي كانت جرافس كبيره ديفيوز ديسيسباير، ويعني وي كود هيلبر، فده كان الاكسبيرينس كان عندنا ما استعملناهاش تاني، وكان لازم نستعمل 8 فرنش جايدنج كافتر عشان تعدي السمارت ستنتس بتاعت البريفرال. دي الاونلي اكسبيرينس كان عندنا، بس دي سوى
دكتور حسام بيه.
I think انه العيانين الميزرابل اللي هم they had CABG before and vessels are very much diseased, they have now a chance, خصوصا اذا كانوا من نوعيه الديسليبيديميك patients في وجود البي سي اس كي 9. I think انه initial experience many of these patients اللي هم كانوا unstable و recurrent وبيحتاجوا زي ما سمعنا من الدكتور شريف 12 stents. I think in the future for these patients will be completely different مع using the PCSK9.
طيب thank you كريم.
دكتور سامح have final.
يعني I think in one of the important messages in this session كمان لازم نفتكرها، ان انا لو عندي سيناريو في عيان عنده ليجن في saphenous venous graft ومدي native artery في lesion, if there is any possibility to open this native artery, it's much better than dealing with saphenous venous graft. And we all of us have this experience that trying to fix the lesion in the native artery and forget about the saphenous venous graft will be much better for the prognosis of the patient. I think this message is very important to hear.
بس ده كتير بيحتاج ساتورو بقى، فصيلة ساتورو.
لا مش بالضرورة إنه يكون سيتو، يعني ممكن يكون سبريشال ليجنز وتايت ليجنز، والجراح لسبب أو لآخر عمل عليها جرافت. If there is a possibility to make the native vessel, this is better for the long-term prognosis of the patient.
I agree completely that if we have any chance to deal with a native artery instead of dealing with a graft, this will be a good option.
وكمان this is the only indication when you have an acute occlusion of a saphenous vein graft. شكرا يا كريم. Thank you very much.